alaikum and good afternoon. I'm Dr. Asif Al-Masab. My topic is comparison of anastomotic leak rate and functional outcome between end-to-end and colonic J-pouch rectal anastomosis after low anterior resection for rectal cancer. I know this is a very lengthy title, sorry for that, and I'm sure none of us are interested in listening to such long topics, especially after the great lunch we had, but I'll try to be easy. So, ultra-low anterior resection is the standard treatment for low rectal cancer, which involves complete removal of the rectum, and the anastomosis takes place below the peritoneal reflection. This is usually where the cancer is, and this is the operation that we do. But the commonest postoperative complications are anastomotic leakage, which may be complete or partial, and low anterior resection syndrome. Now, what is low anterior resection syndrome? It's a complex syndrome involving many symptoms, and there are many consequences. But the simplest one are the incontinence to flatus, incontinence to liquid stool, frequency, clustering, and urgency. Unfortunately, 58% of the patient after low anterior resection has major LARS at 3 months, 46% of the patient at 12 months, 41% of the patient at 54 months. Unfortunately, for some, it may be lifelong. Now, this is a very nice article that was presented in PubMed, which said the main cause of low anterior resection syndrome is the loss of reservoir capacity of the neorectum. And there are other causes as well, like autonomic denervation, radiotherapy, etc. So what do we mean by the loss of rectal reservoir? If you see the picture on the left, this is the normal rectum with the cancer. You can see the wide lumen, and it also distends when stool comes into the rectum. Unfortunately, when we anastomose the sigmoid colon, which is also the narrowest part of the colon, after removing the rectum, the new rectum becomes very narrow, and it has very small reservoir capacity. As a result, the patient has repeated bouts of stool. And this is particularly true for the early postoperative period for the patients. And then comes the anastomotic leak, which of course can be complete or partial. But the most important problem with anastomotic leak, the most important cause of anastomotic leak is the questionable vascularity of the terminal end of the colon. And unfortunately, anastomotic leak itself increases the severity of the LARS, and sometimes patient may have to have permanent colostomy. This causes severe distress to the patient and also to the surgeons. So what can we do? Now, a great man said, for every problem there is a solution. It is up to you whether you are looking at the problem or you're looking at the solution. Now, this was another nice article in the British Journal of Surgery, which says that the terminal end of the colon, if you look at the picture here, the terminal end of the colon, where the line of transaction is, has less vascularity than the proximal part of the colon. So we decided that we should do the anastomosis at any proximal part rather than the terminal part. So many different varieties of reconstruction has been tried, like the coloplasty, which solves the problem of volume but does not solve the problem of blood supply. Again, the J anastomosis or the end to side anastomosis, which solves the problem of vascularity but not the problem of volume. There is only one solution to this, that is the J-pouch, which solves both problems. It increases the volume as well as the vascularity of the anastomotic site. Here is another very wonderful presentation by Diseases of the Colon and Rectum Journal, which said the colonic J-pouch may be the optimal choice after low anterior resection. So we did research for ourselves in our own country, which compared the straight anastomosis with the colonic J-pouch. We are planning to take 50 consecutive patients. We have already collected data from 24 patients and followed them up to 6 months. Our plan is to follow them up to 24 months. And because of the shortage of time, I'm not going into details of the presentation of the article. And our results so far up to 6 months is very, very promising. But also we found there are some problems. like the added staple lines, the additional length that we need, because we always have to mobilize the splenic flexure, the expense, and sometimes it is very difficult to fit it in a narrow pelvis. Now let me show you a video. So we start with the pubic symphysis. Okay, this is the inferior. I'm sorry. Okay, so we started at the pelvic brim. These are the, as you can see, this is the inferior mesenteric artery, the inferior mesenteric vein, and the aorta. We always prefer a meticulous dissection, especially with the hook. You can see the nerves, these nerves must be preserved. Hook gives us the maximum control. That way we always use the hook. We're clipping it, and the high ligation is done. Then we concentrate on the vein, that's the inferior mesenteric vein, which might be ligated at high up near the jejunal flexure, clipping and cutting it. Then we start mobilizing the splenic flexure. We go above the pancreas. We are trying to enter the lesser sac there. As you can see, we have entered the lesser sac. All the peritoneum should be removed from the pancreas. Make sure you don't injure the pancreas. Now we are entering the lesser sac by cutting the greater omentum. There is the spleen, as you can see. Here is the left renal vein, and the left gonadal vein, the left ureter, as you can see. All these structures, especially the ureter, must be intact. Then we enter the holy plane, as we all know about it. There should be no bleeding. In a typical anterior resection, when we never use blood, we never use extra blood, because if you are in the right plane, no bleeding should be there. This is the hypogastric nerve, as you could see. Then we start the lateral dissection. As you can see, the complete mobilization of the splenic flexure is done. There is the spleen. I'm sorry, I have to increase the speed because my time is up, so I'll try to finish it as early as possible. This is the dissection is done. Then we start, I just want to show you one thing. Make sure when you take it out, the blood supply must be adequate. As you can see, there is fresh, beautiful, fresh bleeding. There's the first linear stapler. Stay sutures are given. We form the J. Then we use the stapler to form the J pouch. Then the parsnip suture is given. If anyone wants the full video, I have it with me. If anyone needs it, I can give it to them. Now, orientation is a must. You must make sure the orientation is okay. There you can see the J pouch. And there must be no tension. The donuts are perfect. And the end result is this. Now, another great man said, the simplest solution is not always the best solution, but it is the one that you should consider first. And for me, I think the J pouch is the first solution that comes to my mind, and I think many of us can try it and check it out themselves. Thank you very much.